What's up, Ninja Nerds? In this video today, we're going to be talking about lymphoma that includes non-Hodgkin and also Hodgkin lymphoma. Now, again, this is part of a clinical medicine section. If you guys like these videos, they make sense to you, please support us. You can do that by hitting the like button, commenting down the comment section, and subscribing. Also, down in the description box below, there's a link to our website. If you go there, you can access notes, illustrations, quiz questions by becoming a premium member, and I think that'll truly benefit you. Go check it out. All right, let's get into the pathophys. All right, my friends, so we're going to talk about the pathophys. When we talk about lymphoma, it's an abnormality of lymphocytes, but if you guys go back to leukemia was basically, there was the acute and the chronics, but there was the lymphoid and the myeloid kind of abnormalities. Those were problems where the abnormalities existed in the bone marrow and they just happened to get squirted out into the bloodstream and go and deposit into different organs, right? In this scenario, you're not having that issue. The bone marrow is actually working properly and it's making proper lymphoblasts and pro-lymphocytes and naive lymphocytes, right? So when you think about Hodgkin lymphoma, the abnormality really exists when you get into the lymph node. So when we think about this, let's say here we have our bone marrow, and here is going to be our lymphoid stem cell, and it goes through, turns into a lymphoblast. Lymphoblasts then differentiate into pro-lymphocytes, and then eventually you get your lymphocytes, and this will be your T lymphocyte here, and this will be your B lymphocyte here. From that point, the T lymphocytes will then go where? Well, they go to the thymus, because you know the thymus is where we take the naive T cells, we undergo the selection process, positive, negative selection, everything else. And then from there, we allow these to leave the thymus as primarily, there's a couple other ones, but primarily are they going to leave as a CD8 positive lymphocyte? Or are they going to leave as a CD4 positive lymphocyte? And the importance of remembering that is that these will turn into your cytotoxic T cells and these will turn into your helper T cells. And then you have other ones that could be T regulatory cells. But the big point here is that from the bone marrow, you generate these naive T cells. They go to the thymus, and at the thymus, they undergo maturation where they turn into the CD8 or the CD4 lymphocytes. And then from there, we have a pretty good idea. So again, these, I'll just abbreviate these. These are your cytotoxic T cells, and these are going to be your T helper cells. Now, the B lymphocytes, they from here go to the lymph node. And you know that at the lymph node, there's the efferent lymphatic vessels, all the afferent lymphatic vessels, and then here in the center, there's literally, that's what it's called. It's called a germinal center. This is really where the B cells go. And whenever they get into this germinal center, they undergo the maturation process. And then some of these B cells, they may go and they may differentiate into which type of cells. They may become memory B cells, or they may become plasma cells, where they are designed to produce antibodies. So that's the whole point here. So when we think about the normal lymphocyte pathway, we start at the bone marrow, we get our naive cells, we go to their respective organs, thymus, to mature into these cells, or we go to the lymph node to mature into these cells for the B lymphocytes. It's important to remember, Hodgkin's lymphoma is primarily B lymphocyte mediated. So really when we think about Hodgkin's lymphoma, this is the cell line that is primarily affected. We don't see this fairly with the T lymphocytes. And so really where the disease process is occurring is it's occurring right here in the lymph node, in the germinal center. So here's our germinal center that we're just kind of zooming in on. And so here again, we'll write up here, this is our germinal center. And the germinal center, if you will, is divided into a couple different zones. You know this? So the outer zone, which I want to abbreviate over here, this is called your marginal zone. This is called your marginal zone. That's going to be this layer right here. The next one on the inner side is going to be called your mantle zone. So this is going to be called your mantle zone. And then the most inner zone here is going to be called the germinal zone. This is called your germinal zone. So these are all distinct, and I'll talk about them a little bit more when we get to the non-Hodgkin lymphoma. Funny enough, it's actually relatively important to talk about them there. But we'll have a little intro here in the Hodgkin lymphoma pathophysiology. But these are three important zones because different processes occur here. Let's pretend we take this B lymphocyte, right? And the B lymphocyte here is going to start moving through this germinal center. We're just blowing it up here. So here's our B lymphocyte. The first area that it's going to move to where it has an interaction is this zone. What's this one again? The mantle zone. In the mantle zone, we may have exposure to specific antigens, which I'm going to represent like this. You see these like little maroon dots? These are antigens. So we're going to say that this is the zone where antigen exposure occurs. What is this? What's called? This is called antigen exposure. Will occur here. So what we're going to do is we're going to take this B cell, and I'm going to kind of make it look like this here. We're going to take this B cell, and on that naive B cell, it should have these different types of B cell receptors, which will allow for it to interact, if you will, with these antigens. And so it's going to interact here. When it interacts with the antigen, it should endocytose it. It should take it inside of the cell. And then it should express a piece of it on its MHC2 complex. That's what should happen. So then from here, after it has the antigen exposure, it should then actually make this specialized lymphocyte here, where it'll express a piece of that antigen on its MHC2 complex. And then from here, it may actually vary a little bit on certain types of structures, and it may undergo a process in this stage here called somatic hypermutation. Hypermutation, where it kind of just changes some structures. It moves a little bit of the structures on its receptors. All right, that's really important. So the first step is here, antigen exposure. That occurs in the mantle zone. Then we get into the germinal zone, where we undergo somatic hypermutation. Once you undergo somatic hypermutation, you change the receptors where they're really good at being able to have certain binding affinity for antigens. We've now entered a stage here called the centroblast. So this is called a centroblast. Now what happens is that these centroblasts are supposed to undergo lots of proliferation. Once they've undergone the somatic hypermutation, you should make a bunch of them. Once you've made a bunch of them, you've then primed a bunch of these cells who now have the proper receptors to bind onto these different antigens. From here, it should make a decision. What we're going to do is we're going to undergo a selection process. And we're going to say, okay, let's say that this has a high affinity for an antigen. If this cell has high affinity for the antigen, it will survive. It'll bind the antigen. It's doing its job. And if it does its job, we'll then want it to differentiate and turn into what's called a centrocyte. We'll want it to turn into a centrocyte. And it's done a good job. We've allowed for it to be able to identify the proper antigens that it needs to. So that means that these little receptors are working very well. All right? And we'll represent it. It has good binding to the antigen. That means that we have really allowed for this to work well. All right? Now, if we decide to say, okay, I'm going to take this centroblast here, and I'm going to have him have a poor affinity. This is going to have a decreased affinity for the antigen. Is that a kind of B cell that you would want in your body? No, you don't want a B cell who's designed to identify antigens and then help your immune system to produce antibodies or have your immune system attack those antigens. And so if you have a poor affinity for it, would you want that one to survive? No. And so what should you do? In that scenario, the cell should undergo apoptosis. Let's draw like a cell here that's getting all kinds of jacked up. Look at this cell. It's getting all jacked up. So you'd want this cell to undergo apoptosis. What is this process called here? Again, it's called apoptosis. Now let's say this is a normal process, right? And then technically what should happen, remember I told you once you get done with the lymph node, it goes through, it gets exposed, it undergoes, so this is the first step, antigen exposure right here. Then you go somatic hypermutation here. Then you undergo the selection process, then you have the centrocyte. What happens here? Then it goes all the way out into this outer zone. And when it enters into the outer zone, there's other cells here. I'm just going to draw a couple of them. You know what they are? They're called T lymphocytes. And there are some dendritic cells. You know what they do? They interact with the centrocyte. They can release cytokines, they can interact with their CD4 proteins. And then what should happen is it should undergo a class switching process. What's this called here? It should undergo class switching. And all this means is I'm going to allow for my B cells at this point to determine what type of antibodies are we going to make. I'm going to make IgG, IgA, IgE. And I'm going to switch them from IgM and the IgD. And so it can switch the antibodies that it expresses on its surface or that it produces by the plasma cells. And then from here, it will fully differentiate. And it'll become the types of cells that we wanted. This could become a memory B cell. And what kind of things will it express? It'll have the specific antibodies that we want it to express, the IgA, the IgG, the IgE. Or we can have it become a plasma cell. And this plasma cell will have the capabilities of producing the proper antibodies. Like which ones? The IgG, the IgA, the IgE. So you get the point here. It's dependent, that class switching is what determines their antibody isotype. That occurs right here. And this is mediated by the centrocytes and the, what are these cells here? I'll just write them right here real quick. What are these called? Your T cells. These are called your T cells. All right. Now, this is the normal process by which we take a B cell and we make these cells. Where in the heck, Zach, are you trying to get with this? The process by where this starts to go awry is right here. Cells should want to go this way, right? Normally, and you should want it to go this way. But what happens if I evade apoptosis? What happens if instead this centroblast who has poor affinity for the antigen, instead of it going this way, I start to go this way, and I make these cells. So in this process, what's actually happening is I'm evading apoptosis. So in this Hodgkin's lymphoma, I'm going to evade apoptosis. And you're probably like, how in the heck could you evade apoptosis and then make these weird looking, Frankenstein cells? A lot of different reasons, we'll get into that. But what I want you to know is what actually are these cells? So they're technically centroblasts, but they transform, they have malignant transformation. So they undergo evasion of apoptosis and then they transform into two different types of cells. One is the super high yield one that you can't forget. This is called a Reed-Sternberg cell. This is a Reed-Sternberg cell. This is a identifier. It is a strong identifier of classical Hodgkin's lymphoma. So there's two different subtypes of Hodgkin's lymphoma. One is classical, which is about 95% of the cases, and non-classical, which accounts for about 5% of cases. So this is the extremely most common one. So the presence of Reed-Sternberg cells tells me I took a B lymphocyte, and when it was supposed to undergo apoptosis, I evaded that and made a Reed-Sternberg cell, and I transformed into this weird looking owl eye cell. Now you have to remember, when we look at these cells, we identify them because they have this bilobe nucleus, which we say are owl eyes. So when you see these, I'm not even kidding, it's weird. It actually looks like that. But then also, when you malignantly transform these cells, some of them lose their normal B cell markers and express abnormal B cell markers, and that is these. That's super important. So they'll have these little surface receptors, which are really, really different. They will express what's called CD15 and CD30. So they will be positive for these markers, and they'll be negative for your normal B cell markers, which I'll tell you here in a second. Those normal B cell markers would be what? Well, let's see if we can fit it right here. This would be CD20. That's the big one. There is CD45, but CD20 is the main one. So they'll be negative for CD20 and positive for CD15 and 30. So if I have a patient who I think has Hodgkin's lymphoma, one of the big things is identifying Reed-Sternberg cells. If I see those, I need to know, do they have the abnormal B cell markers? If they do, that tells me it's definitely a Reed-Sternberg cell. Why am I saying I need to identify the markers? Well, look at this one. This is actually called a popcorn cell. And if you look at the nucleus, it looks like it could be a popcorn, all right? And so these are a Reed-Sternberg variant. I'm going to abbreviate this Reed-Sternberg variant. It looks like a Reed-Sternberg cell, but it's not. The other thing here is, when you look at its B cell markers, you don't see any blue ones. You see pink ones. These are CD20 and CD45 positive, but they are CD15 and CD30 negative. That is important to remember. So you can differentiate the subtype, not just based upon the morphology of the cells. You can differentiate them based upon their cluster differentiation proteins, which is important when we get to that in the diagnostic section. All right, and these popcorn cells tell me which kind. They tell me you have non-classical Hodgkin's lymphoma. Now from here, it's important to remember that once we've determined if we have classical or non-classical based upon the type of cells, right? They both evade apoptosis, but the types of cells and their cluster differentiation, it's important to know the subtype. So for example, if we come over here to classical Hodgkin's lymphoma, one of the big things to remember is that the Reed-Sternberg cells, they accumulate in these lymph nodes, right? Because they don't die. They're immortal cells. So they just keep populating like bunnies. The thing with Reed-Sternberg cells is they secrete cytokines, and those cytokines attract in other types of immune cells. And the types of immune cells that gets attracted in determines the subtype. So the first one is nodular sclerosis. This one accounts for, it is the most common. It's somewhere around, I'd say 60 to 70%, but we'll go right now for about 60%. That's how much it accounts for. It's a significant proportion. This one, when you look at it, is you have the Reed-Sternberg cells, which I'm going to abbreviate RS, all right? But you're also going to have other inflammatory cytokines that are released, such as transforming growth factor beta. So they love to release transforming growth factor beta as an example. That transforming growth factor beta will bring in lots of fibroblasts. So what are these cells? These are your fibroblasts. Question for you, what do fibroblasts like to do? They like to secrete fibrous tissue. And so that's what they'll do. They'll secrete a fibrous tissue that'll turn this into more of a nodular type of appearance. So then you're gonna have all of this fibrous tissue that's gonna be occurring. And this is why we get that nodular sclerosis type of look, all right? So all of that orange stuff is your fibrous tissue. Now you may be asking yourself the question, is it really, really important that I know these? Not all of them, but I'd say this is the most important one to remember because it's the most common. The other thing about this one is that this likes to really work in lymph nodes. And it causes, like imagine this, all of this process occurring right here. So if you think about this, all of these guys are going to be affecting this right here. And what you're gonna do is you're gonna get this enlarging area filled with Reed-Sternberg cells and fibroblasts and fibrous tissue. What is that gonna do to this lymph node? It's gonna enlarge it, and you're gonna get lymphadenopathy. And that is the hallmark presentation of lymphoma, is in large lymph nodes. Now, there's different lymph nodes that are more commonly affected in these subtypes than others. The one thing I would like you to remember, we'll talk about it more in the complications, is that nodular sclerosis loves to attack the lymph nodes in the mediastinum, loves them. And so you're gonna see more likely mediastinal lymphadenopathy with nodular sclerosis than you would see with any of these other ones. All right, so the next component here is your mixed cellularity. Now we won't go too crazy on these because this is the primary emphasis, but this may make up somewhere around 30%. And then while we're at it, this may make up 5%, and then somewhere around 5%. So these are your less common ones. Mixed cellularity, the big thing that you need to remember, and this is what I want you to think about, is you're gonna have the Reed-Sternberg cells, right? That's gonna be the big one. You're gonna have some other lymphocytes, a bunch of different types. You're gonna have some plasma cells. But here's the primary one that you want to look for in the exam, the eosinophils. Because that's the one where you don't really see this in the other subtypes. So having the presence of a lot of look at the word, mixed cellularity, that's really where this disease process is going to be kind of highlighting. And so you have all of these different types of cells, and this is going to cause a lot of inflammation, and what is it going to do? It's going to accumulate in that germinal center, and it's going to cause the lymph node to get enlarged. Now, the other one are these two here, the lymphocyte rich and lymphocyte depleted. They're within the name. I don't think we need to really go crazy here. They have lots of Reed-Sternberg cells and tons of lymphocytes. The big thing to remember about this one is that this is a great prognosis. It has the best prognosis out of all of them. You can remember lymphocyte rich, it's the best if you're rich. I don't know if that's a great thing, but think about it. If you could get any of these, this is the one that you want to get. It has the best prognosis. Lymphocyte depleted, look at the name. Lots of Reed-Sternberg cells, very little lymphocytes. And again, this is going to contribute to the lymphadenopathy. But remember, good prognosis, good prognosis. This is a good prognosis, probably the best out of all of them, and this has the worst prognosis. So that is the big thing to remember for these. So if there's a question that comes up and asks, okay, out of Hodgkin's lymphoma, which subtype would have the worst prognosis? You would think lymphocyte depleted. Which one has the best? Lymphocyte rich. That is what I want you to take away from this. This has best prognosis. This one has the worst prognosis. And then for the nodular sclerosis, it is the most common and primarily likes to hit the mediastinal lymph nodes, mixed cellularity, rich in eosinophils. That's really what I want you to take away from all of these different subtypes. But what I also want you to take away is that the Reed-Sternberg cell is the central focus. It's releasing cytokines that are causing inflammatory cells to come to the area and helping it to survive, believe it or not. All these different cells are secreting cytokines to help the Reed-Sternberg cells to continue to keep going. And then eventually they build up in that lymph node in the germinal center and they enlarge that lymph node. And then you get lymphadenopathy. All right, so then we get to the non-classical Hodgkin's lymphoma. With this one, again, remember, this is 5%. This is 95%. With the classical, you have all these different subtypes. With non-classical, it's really just one. It's nodular lymphocyte predominant. And it's nothing crazy to remember here. It's just to remember that they have the popcorn cells. The popcorn cells also do release lots of cytokines, but they draw in tons and tons and tons of lymphocytes that really aggregate around these popcorn cells in a nodular fashion. And again, this is the key thing to take away from that. But whenever these cells kind of really accrue and accumulate inside of that lymph node, and they really like to get into that germinal center, what's going to happen? It's going to cause it to get pretty enlarged. And what's the disease process that'll occur? You'll get enlargement of the lymph nodes, which is called lymphadenopathy. That's really the problematic issue that exists in this disease. All right, so what have we taken away from the pathophys? The things to take away from the pathophys here is that the primary cell that is affected in Hodgkin's lymphoma is the B lymphocyte, not really the T lymphocyte. Where is it occurring? It's occurring in the lymph node. Where exactly is this process breaking down? The germinal center. What was the process that occurred here originally? It was the antigen exposure in the mantle zone. Somatic hypermutation, that's where we kind of change a little bit of the actual receptors on the B cell surface. We go through the affinity selection process. If they don't have an affinity, they're supposed to die. But what if we don't allow them to die and they keep surviving? That's where we get these types of cells. If we have positive normal cell markers and absence of abnormal cell markers, it's popcorn cells. And then you have this type. If it's the presence of abnormal cell markers and the absence of normal cell markers, and it has the allies, it's the Reed-Sternberg cells. From there, look at the inflammatory background to look. If I said has lots of fibroblasts and fibrous tissue, you would say nodular sclerosis. If I said it doesn't have a lot of lymphocytes, you would say lymphocyte depleted. It has lots of lymphocytes, lymphocyte rich. And if I said there's eosinophils and a bunch of other cells, mixed cellularity. All of them accumulate in the germinal center, enlarge it, and eventually lymphadenopathy. That's the key thing to take away. But the question that you have to start asking yourself here is, what in the heck is making these cells not die? Why are they evading apoptosis? All right, so what causes this, evasion or decreasing of apoptosis when it's supposed to happen? There's not a lot of great reasons. What we think, and has been associated with about 50% of the cases we see in Hodgkin's lymphoma, is EBV, so Epstein-Barr virus. This is maybe somewhere around 50% of cases. So that's pretty significant, right? There's other potential etiologies here, and I think it's just important to consider it, but believe it or not, it's kind of the same etiologies that we see to a degree in Hodgkin's that can cause non-Hodgkin's. So it's not really a great thing of having a complete distinction between the two. But another reason could be immunosuppression. So immunosuppression could definitely be driving this process. And we see this a lot in patients who have HIV, AIDS. Now, why exactly? There could be some type of effect of these viruses on these B cells in causing mutations that help them to evade. It also could be because if you think about it, immunosuppressed patients, they have less T cells. T cells are supposed to mitigate this process of helping us to kill cells that we don't really want around. And so could that be a factor? It's hard to say. There's even a suggestion that there could be a family history. And so patients who have siblings who have Hodgkin's lymphoma likely have a very high risk of having Hodgkin lymphoma as well. And so there's a lot of different things, but I think these are the two big things to remember. Now, when we think about this, what could be the reason? It could be that these things are in some way, shape, or form. Let's just represent this. Let's say here I have these viruses. Let's say here I have these viruses. Could they be in some way, shape, or form causing some type of mutation to occur? Right? Somehow they're causing an abnormality here. So here's my mutation. And these mutations in some way, shape, or form are leading to the increased production of a very specific transcription factor. Which one? We think it may be nuclear factor kappa beta. Now, nuclear factor kappa beta is a transcription factor that is involved in regulating apoptosis. And if this is high, believe it or not, it actually tends to do what? Shut down apoptosis. And so this transcription factor may have the ability to do what? To actually inhibit apoptosis. And this is where we might start seeing this process occurring. Could there be other things that are really important to take away from this? Yes. What is kind of important is that Epstein-Barr virus, it has been associated a little bit more with mixed cellularity and lymphocyte depleted. And so that's one thing to take away. I'm not going to write that down because I don't think it's as high yield, but I think it might be something to consider. That one of the big things that we see with Epstein-Barr virus is that this tends to really predominate within the mixed cellularity subtype as well as the lymphocyte depleted subtype. But that's the big thing to take away from this, is that there's a decrease in apoptosis. Why? It may be due to viruses. Epstein-Barr is the big one, immunosuppression is another one, and somehow this may be increasing the nuclear factor kappa beta and suppressing the apoptosis, and this will just allow the cells to continue to survive. All right. From here, let's move on to the next point. The next point here is we have to start talking about, what about non-Hodgkin's lymphoma? What's different about this one? What's the pathophysiology here? We'll talk about that now. So now we're going to talk about non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma, believe it or not, when we compare Hodgkin versus non-Hodgkin, the one that you would want to get is Hodgkin, but also non-Hodgkin's makes up a significant proportion. So probably somewhere around 60% of cases when a patient has lymphoma, it's more likely non-Hodgkin. Now, non-Hodgkin can also have a little bit more of a poor prognosis though. All right, so depending upon which type they have, they could have a very aggressive type of lymphoma. So let's now say, okay, we've come to a situation, a patient comes in, they got lymphadenopathy, they got a really big lymph node. You take a piece of that lymph node, you biopsy it, you see Reed-Sternberg cells. It's the classical. You can also determine if it's popcorn cells. It's the non-classical one. I can determine based upon the look of it, as well as the cluster differentiation, which one is classical and non-classical. And if I do say it's classical, it could be the subtypes: nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. And then I can say if it's the popcorn cells, it probably has a very lymphocyte predominant background, which would be that nodular lymphocyte predominant. And I also told you that the reason why we see this is more likely in cases of Epstein-Barr virus infection, immunosuppressed patients. What about non-Hodgkin? Non-Hodgkin, it's kind of a similar concept where, if you remember in Hodgkin, it really only involved the B lymphocytes. And that's still the case here. 85% of them are usually B lymphocyte related malignancy transformation, but small cases, 15% may be T cell. So if you remember, we take our lymphoid stem cell, turn into a lymphoblast, turn into a prolymphocyte, and then eventually make lymphocytes. So this could be our T lymphocyte, and this could be our B lymphocyte. Now from here, when we've actually taken our lymphoblast and eventually turned it into these types of cells, what happens? Well, we already talked about it a little bit. It'll go to the thymus if it's a T lymphocyte. When it goes to the thymus, it's supposed to mature. And when it matures, it should pop out specific types of cells. Maybe it becomes a CD8 positive cell, maybe it becomes a CD4 positive cell. Either way, you've made a relatively mature cell. In this case, we're not going to talk about the cytotoxic T cells. We're going to talk about the more prevalent one, which is the CD4 positive cell. Now, in T cell lymphoma, when I pop out these types of CD4 positive cells, they really undergo malignant transformation at different parts of the body. So it's not really in the thymus that they undergo their malignant transformation. They can undergo malignant transformation in the skin or in the peripheral tissues. And that's kind of how we really determine the type of T cell lymphoma. Now, let's say here I have this CD4 cell and it undergoes malignant transformation. When we do that, and we actually were to biopsy this tissue of where it's affecting, and we take it out of the blood or we take it out of the tissue, and we look at the cell, one of the big things about this is that the nucleus has a very characteristic look to it. And it's actually kind of high yield to know this. So when I look at these, when I look at these cells, the type of cell that I really want to look for on these CD4 positive cells is I want to see what's called a cerebriform nuclei. I want to look for this cerebriform nucleus, and if I see that, that definitely tells me it's more likely a cutaneous T cell lymphoma. Let me explain what I mean. These CD4 positive cells with the cerebriform nucleus, they love the skin. They tend to hone in the skin. And so here, this guy is going to go and deposit in the skin. And when it deposits in the skin, it can actually cause this malignant process where it can form like little pouchy or microabscesses and cause a lot of skin lesions. If it does that, where it leads to skin lesions only, So you only get skin lesions, and it really deposits here and causes these nasty plaques that we'll show you guys a little bit later and the complications. Then we're talking about a T-cell lymphoma that's primarily staying in the skin. And this is called mycosis fungoides. So if the primary T-cell that we're taking has the cerebriform nucleus and it's only causing disease in the skin and it's not disseminated into the bloodstream yet, it's called mycosis fungoides. When that T-cell decides to leave the skin and enter into the bloodstream and become more of a leukemic type, that's a different one. So now this one is it disseminates. Now once this disseminates and this gets into the bloodstream, we're then called a different type of cutaneous T-cell lymphoma. Believe it or not, it's called Sézary. So this is from a French dermatologist, but we found that this cutaneous type of T-cell lymphoma starts off with skin lesions, disseminates into the bloodstream, and now it's actually kind of a more disseminated cutaneous T-cell lymphoma. So if I say it stays in the skin, the abnormal malignant T-cells, which have the cerebriform nucleus, you would say mycosis fungoides. If I said it got into the bloodstream, it can still cause skin lesions, but now it's in the blood and it goes to other organs, you say Sézary. All right, I like that, it's a little Sézary. Now, from here, the next point is, what if I have another type of malignant transformation? But this type of T cell, it really only malignantly transforms when it's infected. You know, there's a type of infection that's really high yield here. It's called HTLV1. It's the human T cell lymphotropic virus. Usually you see this in like the Japan time, usually in the Japan area. I like to remember this with the HTLV, T for Tokyo. It's a type of T cell lymphoma that we see more within the Japanese culture and even in the Caribbean. But this type of infection, what it does is it'll infect these CD4 cells and it'll make them become malignant. It'll malignantly transform them. And when you actually look at their nuclei, one of the big ways of telling them apart from this one is they have a flower-like nuclei. Now what happens is these CD4 cells, once they've been malignantly transformed by this infection, they get into the bloodstream. And they can go all over the place. They can go to the skin. They can go to the lymph nodes. They can go to the bone. They can go to the liver. They can go to the spleen. They can cause a lot of problems. But this type is called adult T-cell leukemia/lymphoma. So when a patient has T-cell lymphoma, remember, it's a small percentage, maybe 15% of cases who have non-Hodgkin lymphoma is going to be T-cell lymphoma mediated. The two types is, does it have a flower-like nucleus? It could be a peripheral one, especially if there's an infection. Or does it have the cerebriform nucleus? That's more of a cutaneous T-cell lymphoma. Is it in the skin? It's mycosis fungoides. Is it disseminated from the skin in the blood? That's Sézary syndrome. Does it have the flower-like nuclei and it's in the blood? It actually has that history of an HTLV1 infection. That's adult T-cell leukemia/lymphoma. Now, big thing to remember here is once we actually have these cells, especially Sézary and adult T-cell leukemia/lymphoma, these cells like to go to the lymph nodes. So that's one of the things you can actually remember. There's a triad for Sézary syndrome, which is you have these disseminated in the bloodstream, they have lymphadenopathy, and they have a cerebriform nucleus. And they have these skin lesions too. So adult T-cell leukemia/lymphoma is you're going to have these malignant T cells who have the infection of HTLV1. But they're going to go to the lymph nodes and they're going to cause the enlargement of these lymph nodes, and you're going to get, as a result here, lymphadenopathy. So from here, we've discussed the T cell type. All right, that's a small percentage. The big percentage here is the B lymphocyte type. So here, you guys probably remember, I told you the B lymphocytes will go to the germinal center. They'll undergo their proliferation process, maturation process, and from here, we'll either make two types of cells. One is we'll make the plasma cells, who will design to produce antibodies, or we'll make the memory B cells. Well, and you guys remember where that process really actually occurs? Well, if you guys remember, we have the different zones. We're not going to go super crazy because we've already worked hard on this. But the first outer zone is going to be the marginal zone. What was this zone really, really important for? And don't say absolutely nothing. Say it was really, really important because this was where you had the class switching, where you determined it to become a centrocyte to a memory B cell or a plasma cell. What was this one? This was called the mantle zone. And what was the mantle zone good for? This was for the antigen exposure. So this is where you took the actual naive B cell, exposed it to an antigen, and allowed for it to say, okay, I'm going to move into the germinal center and germinal zone and undergo somatic hypermutation. And what was this most inner portion here? This is called the germinal zone. And this is where we had the centroblasts undergoing somatic hypermutation and undergoing the process of selection, where they determine if you want them to have an affinity for an antigen or no affinity for an antigen, right? That was really, really important. So when we take this B cell, it's really important to remember that this guy is going to go where? It's going to first go here. Just let's quick remind ourselves. I'm going to abbreviate it AG. So antigen exposure at this point. What do we use? We use this little color here. Here's all our little antigens for this B cell. It'll then interact at this point, come out, express it. Here's our centroblast. The centroblast will have all of these different types of B cell receptors. It'll undergo somatic hypermutation. When it undergoes the somatic hypermutation, it changes its structure so it can identify different types of antigens. From here, then what happens? After we undergo somatic hypermutation, it then becomes a what? It'll then undergo proliferation and turn into these centroblasts, and the centroblasts will then go through the selection process. When it goes through the selection process, it'll either go to become a centrocyte or it will die. And that was called apoptosis. And how was that dependent? It was dependent upon the antigen exposure. If you have a strong affinity, you go here. If you have a low affinity, you go here, right? So we'll put here a very low affinity, a very high affinity for the antigen. This means that you did a good job with the somatic hypermutation. This means that you did a poor job, and this is not a cell that I would want to have around. Then from here, the centrocyte will have to undergo this process where we'll come out here in the marginal zone. What kind of cells are out here which are going to help it with that process? Do you guys remember? These were our T cells, especially the CD4 type. The centrocyte, now that it's undergone this process where it's really good at identifying antigens, I need it to switch its antibodies. So then from here, where should it go? It should go into the marginal zone where it'll interact here with the CD4 cells. And after it does that, it should switch all of its antibodies and determine which one we want to be. Do we want to become a cell that expresses those antibodies on its surface, or do we want to be a cell that secretes those antibodies outwards and makes these different types of antibodies or express them on the surface? And do you guys remember what this was? This was a memory B cell, and this was a plasma cell. Now, I just wanted to show you guys something of why this is actually kind of cool to think about this with heme. There's so many ways that you can kind of tie things together. Do you guys remember what was the disorder when we have malignancies of plasma cells? Multiple myeloma, right? And then sometimes you can have one in between where it's actually kind of, it's still a lymphocyte, but it's becoming a plasma cell. What was that one called? Waldenstrom's macroglobulinemia. So you can have malignancies that are extending beyond lymphoma that can actually occur in the lymph node. That's why it's kind of important to talk about this stuff. All right, but here, what was this process here where we undergo this? This was called class switching. Now, you're probably like, okay, Zach, we already did a lot of this stuff. Why did you repeat it? I want to repeat it a little bit because it's good to remind yourself, but also, more importantly, malignancies occur in specific zones, and that determines the type of non-Hodgkin lymphoma. If I say that the malignancy occurred in the antigen exposure zone, what was that zone again? It was the mantle zone. And if that malignancy occurs here and I get an abnormal cell, so here's my malignant transformation. Here's where the malignancy occurs. So the malignant transformation occurs here in the mantle zone. What kind of lymphoma would I get? Well, we're going to give it the name based upon the zone. This is called mantle cell lymphoma. It's called mantle cell lymphoma. Now, from here, mantle cell lymphoma, we'll see how this actually happens. It's usually due to a genetic mutation that causes a chromosomal translocation. So we're switching genetic material from one chromosome to the other, making the cell able to proliferate very, very aggressively and rapidly in the mantle zone. That's the big thing to remember. Now, what if it happens here in the germinal zone? So if the actual abnormality is occurring here in the germinal zone, what's this one called? Well, there's not a specific name for the majority of them. Malignant transformation here. This is going to make a bunch of different types. So if you have this malignant transformation and it makes these cells, this could be a couple different types. One is if it occurs in the germinal zone, it could become follicular lymphoma. If it occurs in the germinal zone, it could be diffuse large B-cell lymphoma. If it occurs in the germinal zone, it could be Burkitt lymphoma. Now you're probably asking the question, how would I identify the difference between these two? There is histological differences. This one causes a big chunky nodules to form in the follicle. This makes really large atypical B cells. And this one gives a starry sky appearance. But there's other things that we can use to identify that, such as chromosomal translocations. This has a different chromosomal translocation from this one, and this one, and this one. So we'll talk about these things, but again, it's really important to remember that you can identify these based upon the zone. So if it affects mantle zone, mantle cell lymphoma. If it affects the germinal zone, it could be any of these. One really important thing to remember is that with follicular lymphoma, is that this, we'll talk about this a little bit later in the lymphadenopathy section, but this can cause a very indolent course, where the patient doesn't really get as an aggressive form. But it has the capability of transforming into a diffuse large B-cell lymphoma. So I want to highlight, what is that called when I have the capability of this one transforming into this one? Do you guys remember we talked about it a little bit in the leukemia lecture? It was called a Richter transformation. So it was called a Richter, it was particularly with CLL. It's called a Richter transformation, where you can have a patient who has follicular lymphoma. One of the characteristic things about follicular lymphoma is that it has more of a kind of a waxing, waning lymphadenopathy that's not super severe, and then all of a sudden, lymph nodes get huge, get all lymph nodes all over getting big. They get worse B symptoms, they get super high LDH, and it converted from a follicular lymphoma to a diffuse large B-cell lymphoma. This is the most common type of non-Hodgkin lymphoma. So when we talk about commonality here, this is the most common. When B cells in general, B-cell lymphoma in general is about how much? 85% of the cases of non-Hodgkin lymphoma, 15% for T cell. But when we talk about the most common of all, it's this one. All right. Last zone. If I have a malignancy that's occurring in this zone, what's happening here? Class switching. What would this one become? It's dependent upon that zone. You'd love if this whole thing was called germinal, like zone lymphoma, but it's not. So we get different names for the germinal zones. But this one is called marginal zone lymphoma. This one is the only one that really doesn't depend upon a chromosomal translocation. You can have that present, but it's not the primary one. This one is actually very interesting. It can be due to chronic antigen stimulation, and we'll talk about what that looks like a little bit later. This is usually what we see in autoimmune diseases or in a patient who has H. pylori infections. Now, real quick, when we think about these, B cell and T cell, I told you for Hodgkin, you could identify if it's pretty much always B cell. In this case, it could be B cell or it could be T cell. How do I identify if it's a B cell lymphoma versus a T cell lymphoma? And don't just say, oh, I can look at the microscope. You can, but there's other testing. You notice there's orange proteins on these cells and then pink proteins on these cells? That tells me something. For these cells for T cell lymphoma, it's almost always CD3 and CD4 positive. They're almost always positive for these. It could be any from CD2 to CD8, but this is going to be the most common ones that would really highlight if it's a T cell lymphoma. So if I have a patient who comes in lymphadenopathy, I get a biopsy, I look at the cells, it's hard to tell, I throw them through the immunohistochemistry, and it comes up CD3, CD4 positive, I know it's a T cell lymphoma. But if it comes back and I see these proteins here, where it could be positive for CD19 or CD20, that's my B cell markers. CD19 and CD20. Same thing over here, positive for CD19, CD20. So if these are both having, if I see that that's the case, this would tell me if I have a B cell lymphoma or a T cell lymphoma. All right, so right away, lymphadenopathy, look at the immunohistochemistry. If it comes up CD19, 20 positive, it's B cell. If it comes up CD3 and 4, it's T cell. From there, you determine, okay, is it skin or is it disseminated? Is there infection and multi-organ involvement? From here, I take a look. I have CD19, 20. I know it's a B cell lymphoma, but which type? I'd have to look at microscopy. I'd have to look at all the different types of translocations. And that's where it can get kind of tough. So here's what I want you guys to do. This one's easy because we can differentiate it based upon clinical presentation. This one's not always easy to differentiate based upon clinical presentation. We have to differentiate these based upon causes. With that being said, all of these can, again, really hit that lymph node hard, man, and it can really cause a lot of enlargement of the lymph node. So again, this one more the mantle zone. These are all going to be in that germinal zone that they're going to be enlarging in, and this is going to be primarily in the marginal zone. And if these all occur, or some of them occur here, what are we going to get? We're going to get a real significant enlargement of that germinal center regardless, and that's going to cause an enlargement of the lymph node as a whole. And what is that called? That is called lymphadenopathy. So you're getting the point here, is that the big picture to take away from this is that all of them can cause lymphadenopathy. It may depend upon the particular areas that it occurs and the characteristics of how it actually spreads, but they're all going to have lymphadenopathy. From here, now let's do this. Let's actually say, what are the ways that we could differentiate all of these different types of non-Hodgkin lymphoma subtypes, particularly within the B-cell lymphoma category? All right, so we have to ask ourselves the question, what in the world caused these T cells or B cells to malignantly transform? Whether that's in the cutaneous tissue, whether that's in the periphery, whether that's in the germinal zone, the mantle zone, the marginal zone. Really what a lot of it comes down to is their translocations or mutations, whatever it may be, that's causing a decrease in apoptosis in certain types and an increased proliferation in the other types. Now here's the big thing to remember. When you think about causes of decreased apoptosis, this is going to lead to what? Well, there's a couple different things. One is, this is usually people who express lots of what's called BCL2. So this is the primary, kind of like apoptotic gene, if you really want to think about this one, or the anti-apoptotic gene. And patients who express lots of this BCL2, that really decreases your apoptosis, all right? Other ones that could be relevant to a degree could be Notch2, but I'm not going to go too crazy on that one. But this is the big one. This is the big one. Now, in this scenario, there could be other scenarios, but this is going to lead to your indolent. This is going to lead to your indolent lymphomas. And what I mean by that is indolent lymphomas can be broken down into two types. One is follicular lymphoma, and the other one is called marginal zone lymphoma. With the marginal zone, we don't really think that this is due to the BCL2. I'll talk about it a little bit later. There could be other mutations involved in this one. There could be like a MALT gene that's abnormal. I'll just write that down. There could be an abnormality in what's called a MALT1 gene, but it also is probably more related to autoimmune diseases. But either way, in these scenarios, if you have these types of problems where there's a decrease in apoptosis, these cells, they don't proliferate a lot, they just don't die. And so they can continue to grow slowly, and over time and gradually they'll cause enlargement, but they're not going to be super aggressive and super high grade really quickly. So that's really important to remember. This is going to be your two less severe types of lymphoma. If it's causing lots of proliferation, these cells are proliferating like dang rabbits in the lymph node, that's where you're going to get problems. This could be due to things like MYC overexpression. It could be due to BCL6 overexpression. It could be due to cyclin D overexpression. There could be so many different things, but it's likely that these are the ones that are overexpressed. And what these are doing is they're causing your cells to proliferate and continue to grow and grow and grow. This is going to lead to super aggressive, high-grade lymphomas. Aggressive lymphoma. These are the ones that are going to cause the patient to get higher chance of them not having survival, right? What would these ones be? This would be your mantle cell. This one is very, very aggressive. Probably out of all of them, this is probably the most aggressive one. And then after that, you have your diffuse large B-cell lymphoma, and then you have your Burkitt lymphoma. These are going to be the most aggressive types. And so they have a chance to not only involve lymph nodes, but to spread in the bloodstream and go and infect other organs. The bone, the central nervous system, the bone marrow, the GIT, all over the place, and they can really wreak havoc. So when you have non-Hodgkin lymphoma, you really kind of want the ones where you have a slow growing process, not a high grade replicating process. Now, let's say here is the genes that are going to be doing this process. Again, it could be the BCL2, there could be Notch2, there could be MALT1, all these different things. This is going to be the genes who you're trying to do what? You're shutting down. So this is your apoptosis genes. And this is going to be your proliferation genes. Technically, we have what's called like tumor suppressor and proto-oncogenes. I'm just really simplifying it here. In this scenario, we're trying to inhibit these and stimulate these. And then these will help to make transcription factors that'll help to drive that process. You have to figure out in this thing here is what's really kind of causing this, and it's usually genetic. All right, it's usually genetic. And so this is where I think most students get super stressed out and they're like, oh my gosh, how am I supposed to remember all of these? A lot of the time, 14 is involved in some way, shape, or form. And I'm gonna help you guys to come up with a little interesting way to remember these. So most of the time, there's something being swapped. And usually on chromosome number 14 is the big one. On chromosome number 14, what I want you to remember is there's what's called the immunoglobulin heavy chain, like enhancer gene. And that's really particular to our B cells. A lot of the times what we're doing is we're swapping genetic material from one other chromosome to that immunoglobulin heavy chain. And what happens is when you swap it to the IGH gene, it really enhances that process and you proliferate. We just have to figure out what thing are we passing over to the immunoglobulin heavy chain to form this fusion gene. And this fusion gene is what's then regulating the apoptosis process or the proliferation process. So let's go through that. The first one is if I see 3, 14. So I'm going to go down the order here. 3, 8, 11, 14, and this little random one. I don't want to go too crazy on this one. I just want to briefly, and I mean briefly mention it because it really doesn't belong in this group, but sometimes you can get tested on it, but it's rare. 3, 8, 11, 14, I'm going to go down, all right? So 3, 14 is I'm going to translocate a specific gene on chromosome 3 to chromosome 14. I'm actually transferring the BCL6. So what this does is this actually translocates the BCL6, and so I upregulate the BCL6 gene. And this was doing what? It was increasing proliferation. If I increase proliferation, guess which one this one leads me to? This one leads to the most common type of non-Hodgkin lymphoma. What is that one? Diffuse large B-cell lymphoma. That's how we would differentiate. So if I, for example, lymphadenopathy, take a biopsy, you take that biopsy, you look at them, you're like, okay, I can kind of tell which one it is, but let me figure out if it's B or T. How do I do that? I look at the CDs. If the CD 1920, it's B cell. If it's CD34, it's T cell. From there, I say, okay, it's B cell. How do I know if it's mantle? How do I know if it's in the germinal zone? Or how do I know if it's in the marginal zone? I can kind of take a look at it, but what's another way? Look at the translocation. If I have 314 and an increase in the BCL6 and I have really large atypical B cells on biopsy, it's diffuse large B-cell lymphoma. If I see this one, 814, this one is going to increase the expression of what's called MYC gene. This is the MYC gene. This one is a super proliferative gene. And in that case, I will get which one? Burkitt lymphoma. This is called Burkitt lymphoma. Now, I'll add this up on the top a little bit later, but diffuse large B-cell lymphoma and Burkitt lymphoma are both highly associated with HIV and Epstein-Barr virus. So I want to add that here because both of these super highly associated with Epstein-Barr virus and HIV/AIDS. All right. Now, there is, for Burkitt lymphoma, there's actually 2 types. There's a sporadic form where you just get this mutation and you don't have any driving factor. And that's what we see in the US. But in other areas of endemic processes, such as in Africa or maybe South America, we may see the Epstein-Barr, the HIV/AIDS actually contributing to this translocation. So remember, if it's the sporadic form, it's not really associated with this, but if it's the endemic form for Burkitt lymphoma, it's definitely associated with these. But again, these are probably in some way, shape, or form contributing to these translocations. All right? Now, 1114, this is mantle. It's going to be so this one's going to be the mantle cell. This one actually increases the cyclin D gene. So the cyclin D gene is really powerful proto-oncogene, and you're going to get an excessive amount of proliferation. You're probably going to get one of the most aggressive forms of non-Hodgkin lymphoma. So this is called mantle cell lymphoma. Mantle cell lymphoma really doesn't have any association with EBV, HIV/AIDS. Only these 2 big ones have that association. The 1418, I remember 14 follicular. So this one is going to increase the expression of, what did I tell you for follicular? The BCL2. So you'll have an increased expression of BCL2. And that BCL2 will lead to which one? Follicular lymphoma. Now, all of these were proto-oncos. They're going to cause proliferation. This one is going to do what? It's going to evade apoptosis, or it's going to help to decrease apoptosis, so you just keep surviving. You get those zombie cells. This is follicular lymphoma. And again, not really associated with HIV, AIDS, EBV, anything like that. All right, so the last one is 1118. Now, I boxed it off because it's not as high yield as these other ones. This is one that you can see it, but it's not as high yield as these. This could be associated with, there's like a MALT1 gene that I was talking about. It can actually cause a BRCA3 MALT1 gene fusion protein. It's not super high yield, and I don't think it's really worth remembering, just to know that it can be associated with marginal zone lymphoma. And I'm gonna abbreviate this MZL. Now, the big thing I want you to remember with marginal zone lymphoma is that it's highly associated with autoimmune diseases. That's what I want you to really take away from this. Not as much so with the translocations. So, for example, if a patient has chronic antigen stimulation, especially like let's say in the thyroid, so in Hashimoto's thyroiditis, this causes chronic inflammation of what? Of the thyroid. Remember, you're going to have the antibodies that are attacking the thyroid, right? You're going to have all the anti-TPO and anti-thyroid globulin antibodies that are destroying this thing. And what happens is it gets chronic inflammation. That chronic inflammation can then lead to the nearby tissue, like the lymphatic tissue around the thyroid gland, causing the B cells in that lymphatic tissue to become chronically activated. And over that chronic inflammation, they eventually can undergo mutations. Another one is salivary glands. So this one's called Sjogren's syndrome. So Sjogren's syndrome is primarily affecting your salivary glands, like your parotid, your submandibular salivary glands. And this one, again, you're having autoantibodies. So different types of autoantibodies are attacking the salivary glands, especially the parotid glands, and they're getting inflamed. And the nearby lymphatic tissue where the B lymphocytes reside can get activated, and they can undergo mutations. This can activate those B cells to undergo malignant transformation in the marginal zone and become marginal zone lymphoma. But this is the most important one. And patients who have peptic ulcer disease due to H. pylori positive peptic ulcer disease or gastritis, it can be peptic ulcer disease or gastritis, either one, but they have this H. pylori. That's causing constant inflammation of the stomach. There is associated lymphatic tissue, MALT tissue is what we call it, mucosa-associated lymphatic tissue that's around the stomach. If this H. pylori causes that chronic antigen stimulation, it can activate those B cells in the marginal zone nearby, cause them to become inflamed, and eventually this can turn into a lymphoma. These are technically called maltomas. All right, so they're called maltomas. And so that's really what's associated with marginal zone lymphoma is we have the presence of these maltomas. So they have presence of maltomas. The most important one to take away from this is the H. pylori. Because this is one of those where you could actually have a patient who has lymphoma, and if it is due to this type of process, guess what you can do? You can give them quadruple therapy, the PPI, the bismuth subsalicylate. You can give them amoxicillin and metronidazole, and they'll get better. You don't really have to maybe treat them with chemotherapy. That's why this is really, really important to remember this. All these other ones, you're probably gonna have to undergo pretty aggressive chemotherapy, but this is one where you could actually treat them for this, and they don't need to undergo that. That's why it's so important to remember. All right, so taking away from all of this before we move into the complications is a non-Hodgkin lymphoma can be T or B. You differentiate that based upon the cluster differentiation proteins. Again, also really important to remember is they have these different mutations that occur in certain areas of the lymph node. Depending upon the area determines the type of B-cell lymphoma. And then again, the reason that they undergo malignant transformation and turn into all these different types of B-cell lymphomas is dependent upon the chromosomal translocations. Remember, 314, diffuse, 814, Burkitt, 1114, mantle, 1418, follicular. Can have it associated, don't think about it. Autoimmune diseases, especially H. pylori for marginal zone lymphoma. Again, indolent is the ones with apoptotic genes being underexpressed. The aggressive ones are where you have the proto-oncogenes heavily expressed. All right, let's now go into the complications. All right, my friends, so we now talked about a patient coming in with lymphadenopathy, and we can obviously get to the point where we think that they probably have lymphoma. We just had to differentiate if it's Hodgkin versus non-Hodgkin's, right? And again, once you determine if it is Hodgkin versus non-Hodgkin's, you then can kind of start branching into the subtypes. But I think that's the biggest thing is to determine if it's Hodgkin versus non-Hodgkin's. And not only would you be able to tell that based upon the presence of Reed-Sternberg cells who are, guess what? CD1530 positive, CD2045 negative. Guess what these cells are for non-Hodgkin's? Do you guys remember? They were CD1920 positive, and they would be CD1530 negative. And so that's one easy way, is the presence of Reed-Sternberg cells or not can really determine if it's Hodgkin versus non-Hodgkin's. But there's other clinical features on your exams that you have to be able to recognize. One of the big things here is when we think about lymphadenopathy is that for Hodgkin lymphoma, it's really important to remember that this is more localized. All right, it's more localized. And it's also not diffuse, right? Whereas non-Hodgkin lymphoma is extremely diffuse, it's widespread. And the other thing that's also really important about the lymphadenopathy is that with Hodgkin lymphoma, it tends to really love specific lymph nodes. And it's really the cervical. That is going to be by far the most common. Whereas non-Hodgkin lymphoma, it can really hit any of them. I mean, it definitely involves the cervical, but it's going to go everywhere. That's the other thing. With Hodgkin lymphoma, it's more predictable and contiguous. This is non-contiguous. Now you're probably like, I mean, maybe you don't, but you're probably like, what does that mean to be contiguous versus non-contiguous? And all that means is that when you look at the predictable or non-predictable fashion in which they spread. So let's say, for example, here I start with Hodgkin lymphoma. It loves to involve the cervical lymph nodes. That's the most common. All right. Non-Hodgkin lymphoma can definitely involve the cervical lymph nodes. But here's where it's going to be different. With Hodgkin lymphoma, it spreads in a predictable manner. So where would it go from here? Well, it would probably move here to the supraclavicular, or it could move down here into the mediastinal lymph nodes. Then from the supraclavicular, it could move to the axillary. From here, from the mediastinal, it could move down into the abdominal, and then into the inguinal. So the predictability is what's the key. So it can move from cervical, supraclavicular, axillary, mediastinal, then you get into all the abdominal lymph nodes, and then here, and into the inguinal lymph nodes. It's not like that with non-Hodgkin's. You could have cervical, you could have inguinal, you could have abdominal, and you could have mediastinal all at the same time. So it doesn't move in a predictable fashion. That's the key differences here. Diffuse meaning you could have cervical and inguinal, and they're like, wait, where's the in between? It's supposed to move in a predictable fashion. That's the key. So let's pretend here that I have mediastinal and I don't have any inguinal. I don't have it. I go cervical, mediastinal. All of a sudden, I'm here in the inguinal region. You see the point here? This always moves in a predictable fashion. This can start one place and go completely different. Or I could have it over here in the cervical and it go straight to the axillary. So you get the point. It's non-contiguous. The other thing that's really, really important here is that when you actually take a patient, let's say it has cervical lymphadenopathy, and you have them drink alcohol, there's a big difference here. This is weird. It only happens at maybe 10%, but it's highly specific for Hodgkin, is if you have a patient who drinks alcohol and they have lymphadenopathy, it'll cause pain. So there's alcohol-induced lymph node pain. And if that is present, it's a rare finding, but it's highly specific for Hodgkin lymphoma. So that's one thing to definitely think about. Whereas in non-Hodgkin's lymphoma, they don't have that alcohol-induced lymph node pain. So when you think about this, here's the way I want you to think about lymphadenopathy. It's enlargement of the lymph nodes. And usually this enlargement, when you think about these, they're painless. It's rubbery, and it's usually going to have a patient who, if it's Hodgkin, it's localized to the cervical region and it will spread contiguously. It'll go down through those lymph node chains. If it's non-Hodgkin, it can occur in the cervical, but you could have cervical and you could have inguinal and be like, how the heck did I get from here to here? Or you could be cervical and it could always go all the way to the axillary. So you're trying to see how there's no connection between the two. The other one is if you drink alcohol and it produces pain in the lymph node, it's more specific for Hodgkin. It's not specific for non-Hodgkin. That's the way I want you to think about this one. Let's come to the mediastinal mass, because that's another presentation. It kind of just comes down to the mediastinal lymph nodes. It has nothing really to do with the thymus, as we talked about in acute lymphoblastic leukemia. This scenario, you have lymph nodes that are present in your anterior, your middle mediastinum. And so in Hodgkin lymphoma, do you remember? This is a good test. What was the subtype of classical Hodgkin lymphoma that loves the mediastinal lymph nodes? It was nodular sclerosis. So this is most seen in nodular sclerosis. All right, that's one big thing. Non-Hodgkin's, we don't really see this being that bad unless it's pretty aggressive. So we see this more in the aggressive or high grade non-Hodgkin lymphoma. That's really the big difference here. So you'd see this more in the diffuse large B-cell lymphoma, the mantle cell lymphoma, the Burkitt lymphoma. You wouldn't really see this as much in the follicular, and you wouldn't really see this as much in the marginal zone. For Hodgkin lymphoma, it's usually incidental finding. It's usually an incidental finding. It's not too common for this one to cause too many symptoms. So 50% of the time, your patient's going and getting a chest x-ray or a CT scan, right? So EG is meaning that, what's the example of this? They're getting a chest x-ray, they're getting a CT scan for something else. And all of a sudden, we say, oh, wow, they got some mediastinal mass. Their lymph nodes are really, really big in the mediastinum. That we went work that up, biopsy it, and say, oh, they have Hodgkin lymphoma, nodular sclerosis subtype. Non-Hodgkin, it can actually cause pretty severe symptoms because they can get pretty big and they can cause pretty severe compressive symptoms. And this is usually due to the mass effect. All right, so this is due to the mass effect of that mediastinal mass. So think about this for a second. Let's say that you have these mediastinal lymph nodes. They get pretty big. And as you have this, we're going to call this mediastinal lymphadenopathy, it gets big enough that it can actually start compressing on nearby structures. So let's say that here it compresses into the trachea. If you compress on the trachea, what's that going to do? So if you have tracheal compression, this could cause dyspnea. It may be hard to take air in, so it can cause dyspnea. And if it's a little bit higher, sometimes it can even cause a whistling sound during inspiration. What's that called? Stridor. So it can also maybe cause stridor. What if, in this scenario, it's big enough that it starts compressing on the esophagus? So here we see it compressing on the trachea. What if it's big enough that it's compressing on the esophagus? What could that do? Well, if we compress on the esophagus, this may cause dysphagia. So you really want to watch out for that. So if there's compression of the esophagus, it may cause dysphagia. If it's compression of the trachea, it may cause dyspnea or stridor. Here's the scary one. If it starts to compress on the superior vena cava. Now, the superior vena cava is supposed to bring blood back to the right atrium. But if it doesn't, what could that lead to? This could lead to superior vena cava syndrome. So this could lead to superior vena cava syndrome. Now, superior vena cava syndrome can look a couple different ways. Let's imagine for a second here. Let's say that you compress the superior vena cava. The blood can't go from the superior vena cava into the right atrium. So what's it going to do? It's going to backflow. If it backflows, it's going to backflow into two channels because you have the superior vena cava made up of the brachiocephalics. Brachiocephalics are made up of the internal jugular and the subclavian vein joining. So if there's increased backflow of the internal jugular vein, or there is backflow of the subclavian vein, what's that going to look like? Well, if you get this backflow of the internal jugular vein, it's going to cause the neck to get distended, the face to get enlarged. So this can lead to neck and face distension. And it may even cause some of the neck veins to become a little bit more bulged out. All right? So that's one thing to consider. The other thing is for the backflow of the subclavian vein. If it backflows from the subclavian vein, this may cause arm and chest distension and swelling. So here, let's actually say neck face swelling and the associated veins that may be in these areas. So you may have some jugular vein distension. You may have some cephalic or maybe even some basilic vein popping. And the other thing is that they have a bluish hue. So they may have like a slight bluish hue to the skin. This is usually what we would see in a classic case of superior vena cava syndrome. It actually looks a little bit like this. So we see in this patient who has superior vena cava syndrome, they'll have a lot of swelling from compression of that superior vena cava. What's the biggest concern? What I would actually be worried about, and this is what I would really dedicate as an emergency, because technically we consider superior vena cava syndrome an oncologic emergency. I would say it's truly only an emergency under certain circumstances. One is that you have an increase in the ICP. Think about this, guys. Think about it. The jugular vein is going to drain the cerebral venous sinuses in the brain. bring the blood down eventually to the supravena cava in the right heart. What if a patient already has higher intracranial pressure and you clog off their jugular vein? You can impede that jugular venous drainage and increase their ICP more. That's an emergency and I gotta deal with that quick. Another one is hypotension, so low blood pressure. Think about this. What's the supravena cava supposed to do? Supposed to bring blood, venous return to the right heart. If you compress it enough that you don't get venous return, that could be a problem. But also, if the mediastinal adenopathy is big enough that it's compressing on the heart, you can get kind of like a cardiac tamponade picture. That needs to be addressed. And then lastly is if you have laryngeal edema. This is because in a patient who has this internal jugular vein backflowing, it can actually kind of go backwards into some of these actual like anastomoses around the veins around the neck, and they can actually leak out and cause the larynx to become super swollen, and a patient can go into respiratory distress. These are the things that I need you guys to consider. This is more of an urgency. This is an emergency. Again, what are you going to see mediastinal masses more common in? You'll probably see them more often, to be honest with you, in Hodgkin lymphoma. That's going to be the more common one, but it's really important to remember it's only in this subtype, and oftentimes they're pretty much asymptomatic. If they do, they may get a little bit of this dyspnea, they may get a little bit of dysphagia, but they oftentimes don't have the true supravena cava syndrome. In non-Hodgkin lymphoma, it's not as common, but you're going to see it in the aggressive subtypes, and if they do have it, it usually presents with more severe symptoms. That's the difference to take away from it. All right. Lymphadenopathy is different between these two. Mediastinal lymphadenopathy is different between these two. What else is another thing to differentiate between the two? Let's go to the next part. All right, so B symptoms is another potential presentation that we can think about in like lymphoma. So it's important to distinguish these from each other. So again, particularly Hodgkin's lymphoma, this one will be B symptoms that are going to be way more common. You just tend to see this a little bit more commonly with Hodgkin lymphoma. So it's definitely going to be more common. Now, non-Hodgkin lymphoma, it can occur, but it's usually more in the aggressive subtypes. With Hodgkin lymphoma, one of the big things that you have to remember is B symptoms is usually classified as like fevers, night sweats, and weight loss. Usually it's like greater than 10% of your weight within like a 6 to 12 month period is how we would consider that. One of the other things that are really important to remember here is that Hodgkin lymphoma can actually have more of a periodic or cyclical type of presentation. We call that a Pell-Epstein fever. Whereas you will not see any type of cyclical or, fluctuating types of like B symptoms in a patient with non-Hodgkin lymphoma. So there will not be any presence of this Pell-Epstein fever. So that's ways that we could potentially differentiate these two. Now, with B symptoms, the concept behind this is that either you have Reed-Sternberg cells or malignant lymphocytes, and they're producing particular cytokines. They could be making things like interleukin-1, tumor necrotic factor alpha, interleukin-6, and they're pumping these things out, man. So these cells here that are formed within the lymph nodes are pumping out these potential cytokines. What we know is that some of these cytokines are pyrogenic, and so they love to go to the hypothalamus, especially these. They're going to go target the hypothalamus, and they're going to tell the hypothalamus to reset its thermostat. And this is going to lead to fevers and night sweats. And it's also going to target the hypothalamus hunger center. And it's going to change the patient's satiety to be having an early satiety, or they're not going to want to have the desire to eat. And this can lead to weight loss. This is the way that we oftentimes see this type of presentation, is the hypothalamic activation that leads to the fevers and night sweats from the body's thermostat being upregulated, and then weight loss due to early satiation. So we're going to activate the satiety centers. Another thing here is when a patient has fevers and night sweats and weight loss, we get worried potentially, could there be an underlying like infection or an inflammatory process going on? One of the other things that we see with this is that interleukin-6 also is a very strong stimulator of the liver. And it can act on the liver and increases the liver's production of acute phase reactant proteins. And so another thing that you actually may see in these diseases, it's not really critical that you test for it, but you may see an increase in their CRP. And so there's a lot more proteins that can bind onto the red cells and weigh the red cells down during the sedimentation rate. And so you may see an elevated CRP and an elevated ESR. So these are indications of acute phase reactant proteins. That's what's really important to remember, is that you can have fevers, night sweats, weight loss, elevated acute phase reactant proteins, and this could suggest B symptoms that we can see in patients with lymphoma. It's more common in Hodgkin, Less common in non-Hodgkin unless it's the aggressive subtype. One can be cyclical, where you can have 2 weeks on where you have these symptoms and then 2 weeks off, and then back on to 2 weeks. And you could see that potentially with Hodgkin. You will not see that with a non-Hodgkin. It's more continuous. All right. That covers the B symptoms. Let's move into the next thing which we really need to talk about, which is the extranodal disease. So it's when these actual malignant lymphocytes, Reed-Sternberg cells, invade tissues beyond the lymph nodes, such as the CNS, the skin, the GIT, etc. All right, so now let's move on to extranodal disease. This is very common in non-Hodgkin's lymphoma. So that's what I really want you to take away from this. So kind of as we continue to build upon our differentiating factors, we know that non-Hodgkin lymphoma is usually diffuse lymphadenopathy. It's not contiguous. There's usually no alcohol-induced pain associated with that. They have B symptoms that are usually in the aggressive subtypes. They can have mediastinal masses. If they do, it's going to cause definite symptomatic presentation, and they have extranodal disease. While that is being said for Hodgkin lymphoma, it's extremely rare. It's not common for Hodgkin lymphoma to involve extranodal tissues. That will cause, again, more of the localized lymphadenopathy. That is a predictable fashion in which it spreads. It is associated with alcohol-induced pain. They do have B symptoms that are going to be more common, and they can potentially be cyclical. They can have mediastinal masses that we may never know about, and it may be incidental findings. But if we look for extranodal disease, we aren't often going to find that. Now, with that being said, it still can happen. So let's think about the extranodal tissues that are most commonly affected with a couple other little perks that I need to discuss along the way. Now, let's say here I have this malignant tissue. It consists of tons and tons of lymphocytes. These things can go and spread. And let's say it spreads to the central nervous system. It invades the meninges, it invades the brain. What are the potential complications that can arise here? Well, one is that if it invades the central nervous system, you can sometimes get like masses. I'm talking like you can actually get like a big mass that can form inside of the brain. It's like a tumor. I'm not even kidding. It's called primary CNS lymphoma. This is very common in non-Hodgkin's lymphoma. And we oftentimes, just a little sub thing to talk about it, it's actually oftentimes extremely associated with HIV/AIDS. Believe it or not, this is an AIDS-defining illness. So if a patient has a mass inside of their central nervous system, brain, spinal cord, usually it's the brain, and we go ahead and we see that they have HIV/AIDS, we do a biopsy and we see that this is actually lymphoma-related tissues. That's going to be associated with primary CNS lymphoma. Again, this can also be associated with, usually any of the aggressive subtypes. So we can see this pretty often actually in diffuse large B-cell lymphoma. That's one thing. And again, it can actually look like this on imaging. Another thing that can happen here, and it's really important, is it can invade the meninges. So it can cause a mass, but it can also invade the meninges. And if it invades the meninges, you can literally, I'm not even kidding, you can get meningitis. So these patients can also get meningitis. Watch out for that. Another thing that can happen here is that sometimes you can actually have the lymphoma tissue accumulate around the actual epidural space and in the actual spaces around the spinal cord. And so sometimes you can get masses that form around the spinal cord and they start compressing on the spinal cord. And so you can get compressive symptoms. And so this could potentially lead to what's called spinal cord compression. How is this relevant? Let's say that I'll tell you, for example, I have a patient who has non-Hodgkin lymphoma, right? They've been diagnosed. They come into the hospital now, and they have it in their medical chart that they have a history of non-Hodgkin lymphoma. Let's say it's aggressive type, like diffuse large B-cell lymphoma, which is the most common. And all of a sudden they come in with lower extremity weakness and sensation loss and bowel and bladder dysfunction. And you get some imaging and you find a mass around their spinal cord. That could be indicative of spinal cord compression. That's an oncologic emergency. We need to give them steroids and try to potentially see if we can do radiation therapy to try to shrink that mass so it's not compressing the spinal cord. If a patient comes in, they have a defined history of potentially non-Hodgkin lymphoma, and all this, so they come in with like headaches and nausea and vomiting, and they come in with photophobia and symptoms that are similar to meningitis. That could be the reason. We'd have to do a lumbar puncture, take off some of the cytology, and see if we can find those lymphoma-related cells. And again, if a patient comes in and they have a mass inside of their brain, and they have a history of HIV/AIDS, they have a history of diffuse large B-cell lymphoma, it could be primary CNS lymphoma, which this actually formed. Now, here's a little thing to remember. Sometimes with primary CNS lymphoma, it doesn't actually have to involve a lymph node prior. It can actually just develop in the brain on its own. That's oftentimes the definition of primary CNS lymphoma. So if it's a mass in the brain, this one can be affected. If it's a mass around the spinal cord compression can occur. If it affects the meninges, you can get meningitis. Now, where else can it affect? It can actually go down here to the GIT. So it can actually involve the GIT, particularly the stomach, and can even involve the ileum. When it goes to the stomach, there's actually important areas. There's some mucosa-associated lymphatic tissue around the stomach called the malt. And so sometimes what can happen is you can actually get what's called a gastric malt lymphoma. And so this is oftentimes seen associated with which one? Which one? Marginal zone lymphoma. So you can see this with, I'll abbreviate this one, marginal zone lymphoma. Another thing that can happen is sometimes you can have the lymphoma tissue can actually become, the lymphocytes invade the lymphatic tissue around the ileum. And it can actually cause enlargement of that ileal tissue. And it can start to narrow the ileum. And as it starts to narrow that ileum here, so let's say here it gets a little bit narrowed. Now what can happen? If I have inflammation here that actually starts compressing and narrowing the lumen of the small bowel, what could you get? You get a small bowel obstruction. So we want to watch out for things like a small bowel obstruction. Which one is this one seen with? This is seen with what's called Burkitt lymphoma. This is seen with Burkitt lymphoma. All we're looking at is where these actual lymphoma cells are invading. If they're invading the ileum, around that malt tissue, this can cause a small bowel obstruction or even intussusception. If it's invading the gastric malt tissue, this can lead to gastric malt lymphoma. That's only seen in marginal zone lymphoma. What else? Let's say that it actually invades the bone. If it invades the bone, when it invades the bone, sometimes what can happen is you can have a couple different things. One is you could actually have these osteoclasts, they could be activated. So sometimes we have certain types of malignancies, and I would say the biggest one to remember is if a patient has what's called adult T-cell leukemia/lymphoma. In that type of disease, let's say here we have these lymphoma cells, right? They've infiltrated. If they've infiltrated into the bone marrow, they can release cytokines. And these are called PTHRP. And that PTHRP will hit these osteoclasts. So here's my osteoclast. And this will cause the osteoclast to break down the bone. And when it breaks down the bone, you can get two things that can occur: lytic lesions, and then what are you actually releasing from the bone or liberating from it? Calcium. So I can get lytic lesions that could form, and I could also get an uptick in my serum calcium. And so that's really, really important to remember that if you see the presence of lytic lesions and hypercalcemia, and you have to be thinking about this, that flower-like nuclei where they had the HTLV1 infection, that's an adult T-cell leukemia/lymphoma. That's almost always associated with this lytic lesions, hypercalcemia, and the flower-like nuclei. And again, that's a really, really important one to remember, that you see these more in that Japanese, Caribbean culture. Now, other types of lymphoma can just directly go into the bone, and they could just cause direct activation of osteoclasts. So other malignancies can also do this, especially like diffuse large B-cell lymphoma. Another big concern though with infiltrating the bone is when you infiltrate the bone with these kind of lymphocytes and you crowd out the space in the bone marrow. Let's say that you crowd out the marrow. So now you have all these lymphocytes, they're crowding out that marrow. If you crowd out the marrow, you leave less space for allowing for the production of other blood cell lines. And so then now you're going to decrease the production of red blood cells. And so you're going to inhibit the production of red blood cells, inhibit the production of platelets, inhibit the production of white blood cells. What's this called now? If you decrease the production of all of these cell lines, this can lead to what's called pancytopenia. So what I'm trying to tell you is that if a patient comes in with non-Hodgkin lymphoma, and all of a sudden they have pancytopenia, what are you worried about? I think that this could have infiltrated the bone marrow. If they come in with hypercalcemia and lytic lesions, I'm worried that it could have infiltrated the bone. This can happen in ATLL, the adult T-cell lymphoma/leukemia, or it can occur in any of the other types of lymphomas, the non-Hodgkin lymphomas. And it could just literally be activating osteoclasts directly. But this is something to think about, that it's invading the bone. If a patient comes in, they have non-Hodgkin lymphoma, and all of a sudden they're developing a lot of abdominal pain and distension and decreased bowel sounds, and maybe they're having some rigidity, some guarding, and I'm worried that they're starting to have potential signs of a bowel obstruction. That could be due to Burkitt's lymphoma. If they're coming in and they have a recurrent history of peptic ulcer disease or gastritis, and I look and I get an EGD and I see that they have a big mass inside of their stomach, that could be a gastric malt lymphoma, which is seen in marginal zone. What else should we be considering? Well, what if there's invasion of these lymphocytes into the liver and the spleen? Well, this could lead to hepatosplenomegaly. hepatosplenomegaly. And you can see this in really any of them. You can see this in almost any of them. All right? This would potentially lead to that early satiety, the nausea, the potential anorexia, the weight loss, maybe even a palpable left upper and right upper quadrant. But this is the big thing, because as you get a bigger liver and spleen, it's compressing on the stomach and making less room. The other thing that's really, really important is, what if some of these actual malignant cells infiltrate the skin? You can get skin lesions, dude. And this is really important to remember. So let's say I start off with these pruritic, like big papular lesions, pruritic papules is what we're going to define them as. This one is almost, if you see these pruritic papules that look like this, it's almost always associated with mycosis fungoides. Mycosis fungoides. That is really, really important to remember. Now, if I see that a patient has erythroderma, which is just a diffuse, really, really, really nasty red rash almost over their entire body. This one is almost always seen with Sézary. All right, so Sézary syndrome. Now, with that being said, if I see pruritic papules, mycosis fungoides, if I see erythroderma, which looks like this, it's associated with Sézary syndrome. So if I start to see potentially a patient has a history of Hashimoto's thyroiditis, and they have a, let's say, a thyroid mass, I would be thinking potentially about a marginal zone lymphoma. So that's one thing to think about. If they have a history of what? History of Hashimoto's thyroiditis, and now they're presenting with a thyroid mass, think about marginal zone lymphoma. If they have a history of Sjogren syndrome, and all of a sudden they present with a submandibular or parotid mass, so it's oftentimes the parotid is going to be the big one that gets affected. A parotid mass, you may be thinking about marginal zone lymphoma. And again, these are your maltomas that are actually forming here. So you get the point, man, that extranodal disease can be pretty tough, where a patient can come in with lymphadenopathy, they can come in with B symptoms, they may have a mediastinal mass. But what's really critical to know is it basically infiltrating other organs? If I say that a patient has neurological symptoms, you could think about potentially that they have a headache, if they have nausea, if they have behavioral changes. You may think about CNS lymphoma. If I say that they're coming in with weakness and sensory losses and bowel and bladder dysfunction, you may think about potentially spinal cord compression. If I say that they're coming in and they're presenting with abdominal pain, and maybe it's in potentially associated with nausea and vomiting, then you may be thinking about a bowel obstruction, or maybe even a gastric malt lymphoma. If I'm saying that they're coming in with potential lytic lesions and bone pain and fractures and hypercalcemia, you may be thinking about adult T-cell leukemia/lymphoma. If I'm saying that they're coming in with pancytopenia, that means we've infiltrated the bone marrow and we've actually affected the production of other cell lines. If I say I'm affecting the skin or the actual spleen and the liver, you would definitely be considering that, especially if I said pruritic papules associated with mycosis fungoides, or if I said that there's actually erythroderma associated with Sézary syndrome. And if I say that there's a thyroid mass or salivary gland mass, especially the parotid, you're thinking about those marginal zone lymphomas. So there's a lot of different extranodal tissues. And believe it or not, knowing particularly the specific ones that I kind of pointed out, or what I really want you to take away from this, but oftentimes the most important thing to take away from extranodal disease is if it's present or not. And the way that we can do that, as we'll talk about it later, we do what's called PET CT scans. And so you do positron emission CT scan, where you actually give a patient glucose with a radio-labeled fluoride 18 on it. It goes to cells that are eating them up, cancer cells. So if we have cancer in these tissues, guess what's going to happen? They're going to light up like a Christmas tree on that actual scan. And depending upon where they're involved, or if they're involved, determines if there's extranodal disease. What's the point of that? It tells us what's the treatment that we're going to be going with, and what kind of stage of lymphoma do they have. All right, let's finish off with the last part here, which is basically tumor lysis syndrome. Now, we talked about this a lot in acute leukemias. Do you remember which one it's more common in? ALL. You can see it in AML, but it's definitely more common in ALL. For tumor lysis syndrome, it's pretty much never happening in Hodgkin's lymphoma. It is extremely rare. For non-Hodgkin lymphoma, this is common only in the aggressive subtypes. All right? So for example, Burkitt lymphoma, diffuse large B-cell lymphoma, you can definitely see this because they have some heavy cell turnover and heavy tumor burden. And so if these patients have this, and let's say that they have lots of cell turnover, right? Or they get hit with chemotherapy. Because remember, that's the big thing. You get a patient who gets hit with chemotherapy, What's the big problem with that? Well, it's going to kill these cells. If you kill these cells, what's that going to do? That's going to stimulate these cells to start popping open. And you're going to trigger this lysis. All right, so you're going to have increased lysis of the tumor cells. If you lyse these tumor cells, what are they going to do? They're going to spill out their intracellular contents. When they spill out their intracellular contents, they're going to spill out potassium. So they're going to spill out tons of potassium, and this is going to cause hyperkalemia. How does hyperkalemia oftentimes present? It presents with cardiac arrhythmias, or it can present with ECG changes. Again, we've talked about this a couple different times, but do you guys remember what the arrhythmias that are most commonly associated with this are? Bradycardia, cardiac arrest, or it can present with peak T waves. It can present with a prolonged PR interval. It can present with a flattened P wave. It can present with a wide QRS complex that can break down to a sine wave and develop VTAC VFib or asystole. They can pop open and release another potential molecule. What's this one called? Uric acid. And do you guys remember when you have lots of uric acid, what's this guy doing? That hyperuricemia, this is a nasty little molecule, remember? Represented with these little blue dots. And what are they going to do? They're going to get filtered across the glomerulus. As they get filtered across the glomerulus, what are these? These are nephrotoxic, my man, right? And so they're going to get into these tubular cells, and they're going to do what? They're going to cause damage to the tubular cells. As they cause damage to the tubular cells, this is going to cause acute tubular necrosis. Acute tubular necrosis will then progress to a acute kidney injury. The problem with this is that, yes, you lose these cells and they stop functioning. So they lose the ability to secrete chemicals. That's one problem. But the other thing is, as these cells die, what do? They slough off. And as they slough off, they release these dead epithelial cells that form these casts that block up and obstruct the tubule. This is called an obstructive uropathy. And what we know about obstructive uropathies is that you impede the normal flow. So if you impede the normal flow, which is you're supposed to filter things off, what's that called? GFR. And this is supposed to move down this way, but it doesn't. It goes this way. That's the big problem here. So obstructive uropathies, they drop your GFR. And if you drop your GFR, that leads to an abrupt rise in the creatinine. And that's what leads to this process. Because think about this. You're supposed to filter off waste products and you're supposed to secrete waste products. If I can't filter them to get them out into the urine and I can't secrete them because the cells are dead, what am I going to do? I'm not going to be able to get rid of all these waste products. And so my creatinine goes up, my potassium goes up, my water goes up, my protons go up, my urea goes up. And what do I end up with? A bunch of dang complications of AKI. Like what? I can have an increase in creatinine, which is what defines an AKI. I can have a uremia, which is the BUN, and if it starts causing symptoms, that's called uremia. I can have an increase in potassium, which can cause hyperkalemia, an increase in water, which can cause hypervolemia, and an increase in protons, which can cause a non-anion gap metabolic acidosis. You get the point. This is a problematic issue. So that's why it's really, really important to identify this. We don't want that uric acid to be causing that damage. That's why we actually keep a very close eye on these electrolytes. And last thing to remember here is I can also pop out phosphate. Now, whenever you have high levels of phosphate, the problem with this one is it loves to bind up your calcium. And when you bind up calcium, what's the problem with that? Well, if I bind up my calcium, especially the free calcium, that'll lower my serum calcium levels. And so if I do that, what's going to happen to my serum calcium? It's going to go down. When you drop your serum calcium, what does that do? Well, remember, on the actual cell membrane of neurons, I'll represent this in here in blue, we have sodium channels. Calcium is normally supposed to block the sodium channels. If you have less calcium, will it block the sodium channels? No. So what happens? Sodium rushes in. If sodium rushes in because it has no calcium to block it, what's that going to do? This neuron's going to fire like a son of a gun. This is going to generate crazy action potentials. And these action potentials are usually going to present in what's called tetany, or neuromuscular type of dysfunction. And so that will present with the tetany presentation. What does that look like? Well, they could present with perioral paresthesias. They could present with Trousseau's sign, or which is basically whenever you try to inflate the blood pressure cuff, right? They get that carpal pedal spasm. Or you try to tap on their facial nerve and they cause Schaafstack sign. These are potential presentations that you have to consider. So again, we can see this tumor lysis syndrome really only in the non-Hodgkin lymphoma as they have heavy tumor cell burdens and the initiation of chemotherapy. That's a lot of complications, a lot of things to talk about with lymphoma. Let's put it all together in the diagnostic approach. If you have a patient who comes in and they have a painless, rubbery, and large lymph node, all right, that's one thing to start thinking about lymphoma. On top of that, if they got B symptoms that's associated with it, maybe it's periodic, but they have fevers, night sweats, chills, weight loss, definitely concerned about lymphoma. you happen to get a chest x-ray or a CT scan and incidentally find some enlarged mediastinal lymph nodes, or a patient came in symptomatic with superior vena cava syndrome, dyspnea, stridor, dysphagia, and you happen to find that upon imaging because of those symptoms, that should be concerning for lymphoma. Extranodal disease, whether they come in with simply a jaw mass, which is pretty obvious, symptoms of a bowel obstruction, a thyroid mass, a salivary gland mass, hypercalcemia, pain from lytic lesions, periodic papules, erythroderma. They come in with confusion, headaches, neurodeficits. They come in with fevers, neck pain, vision changes. They come in with weakness of the extremities and sensory deficits and reflex loss and urine retention. These are all things that are suggesting a potential disease process. It's a lot harder to identify this lymphoma based upon extranodal disease unless it's screaming in your face on the actual vignettes. But oftentimes it's about piecing these together. If we have these, the first thing to do is to target the enlarged lymph node. Do an excisional lymph node biopsy and take a piece of this tissue, or pretty much this whole lymph node, and then what you need to do is examine it under the microscope and really get an idea of what the heck it looks like. If you look at it under the microscope and you see these, oh, here's our friends, the Reed-Sternberg cells. That definitely screams Hodgkin's lymphoma. Another one is if I see the popcorn nucleus, that still screams Hodgkin's lymphoma. So that's what I'm starting to think about is, could this be Hodgkin's? If I don't see Reed-Sternberg cells, but I see these weird appearing B cells or T cells with a cerebriform nucleus, a flower nucleus, they got weird patterns on their histology, then it could be non-Hodgkin's. How do I further go along this path? All right, well, let's take a second and say we get the immunohistochemistry. That looks at the CD4s, that looks at the CD3, it looks at the CD15, 30, 20, 40, all those to really help me to delineate between the two. So if I say CD15 and 30, oh, that's the ones which shouldn't normally be present on B cells, especially if they don't have the other ones. That's Reed-Sternberg cells. That's classical, baby. If I see CD15 and 30 is negative, but they got, CD20 and 45, that could be non-classical then, especially if we're coming from this Reed-Sternberg cells or popcorn cells. All right, cool. CD3 and 4, that's T cell, baby. That's T cell lymphoma. And if I see CD19 and 20, that could be a B cell lymphoma, especially if there's no Reed-Sternberg cells or popcorn cells present, and it looks kind of really atypical appearing lymphocytes. All right, so we've kind of gone down that route. Well, then if I say, okay, I have the Hodgkin's, I want to kind of reassess these and look at them a little bit more to determine the subtype. How do I do that? Well, let's say I do that and I say I see nodular sclerosis, and I characterize that just by, if you guys remember, there's the Reed-Sternberg cells and they're going to have fibroblasts, but what's the key thing that's all the way around them? That fibrous tissue. You see how there's fibrous tissue here? That's classic, man. That's usually pretty consistent with nodular sclerosis. That's 60% of the cases. If I say mixed cellularity, it's going to be, again, what's the big thing here? I'm going to have a lot of these Reed-Sternberg cells, which you can kind of see right here, right there, and right there. But what's around them? That's the key thing. Do you see these like little red cells with like the sunglasses that are kind of popping here, but these kind of like red? This one's a perfect example. You see this guy right here? That's an eosinophil. And that eosinophil is characteristic of mixed cellularity in 30% of cases. If I see this one and I got the Reed-Sternberg cells and this is just loaded with lymphocytes, that's lymphocyte rich. Well, how do I know if it's loaded? Take a look at this one. This is lymphocyte depleted. You see how there's barely, here's the Reed-Sternberg cells. Do you see the lymphocytes? There's not very many. That's one of the key ways that we can differentiate these. And then if I wanted to go the route of the nodular lymphocyte predominant, all I need to do is find those popcorn cells. If I see the popcorn cells, I'm good to go. And I got myself so that 5% of cases, the nodular lymphocyte predominant. So there we go. We've covered all the Hodgkin's lymphoma. This one's a little bit more challenging though. So then what we do is with T cell lymphoma and B cell lymphoma, you want to reassess that look of it, see what kind of nucleus it has, look at the surrounding tissue around those weird lymphocytes, but also remember I told you about chromosomal translocations like 314, 814, 1114, 1418, all those? I need to see if those are present because that can correlate with which type of B cell lymphoma. So let's say, for example, I do that. I want to find the cutaneous T cell lymphomas. So if I want to do that, I'll say, okay, that's my cerebriform nucleus. So here it is. That's the cerebriform nucleus. I'm at this point going to say it's either mycosis or it's which one? It's Sézary. If I say that this is erythroderma, that's usually, and it's in the blood, that's Sézary syndrome. If I say that there's pruritic papules and these things are not in the blood, that's mycosis fungoides. All right, cool. Next thing is, I don't see a cerebriform nucleus. I see a flower-like nucleus. Tell me that doesn't look like it. That's pretty cool, right? That right there is indicative of adult T-cell leukemia/lymphoma. So what would I be looking for to attain testing on? This right here, the HTLV1. And if that came back positive, boom, I have nailed the diagnosis because I found the lymph node, I found the cell, I found the CD3/4, and I confirmed it with the HTLV1 testing. Slam dunk diagnosis. The next part, and then you remember I told you the extranodal spread. If you're really thinking about it, what other things would I be looking for? The lytic lesions, the hypercalcemia. So that's another thing that you can add on the extranodal spread. It's a little bit more tough to just pick it up right away with that. Follicular lymphoma. With this one, I'm looking at them, and again, I see these like nodules of just clusters, just follicles packed with all these neoplastic cells. But what's the key thing? Remember I told you 1418 translocation. That would come up on the cytogenetics, and they would have an increased expression of BCL2. All right, that's really where we kind of leave that one. Diffuse large B cell. This one, it looks really atypical. And I'm not kidding. The cells are huge. So you see how these cells are like really, really large. Their nucleus, you can see it, but then around them, they just got a really large amount of cytoplasm. That's usually pretty consistent with diffuse large B cell. Remember, it's 314. And this one has lots of BCL6. All right. It also can have a 1418 translocation as well. But the real big thing here is lots of BCL6 and also lots of BCL2. All right. Burkitt's lymphoma. This is the classic one you will see on the exam. It's a starry sky appearance, all right? So when you look at this one, you see the starry sky appearance, you automatically think Burkitt's lymphoma. This one, super aggressive. You want to remember B looks like an 8. That's an 8/14 translocation with lots of c-MYC expression, all right? And then next is the mantle cell lymphoma. This one is hard to pick off histology. It's usually these lymphocytes that look like they're kind of condensed and they have like these cleaved looking appearances. This is what we would see here, but the real key thing for mantle cell is which one is it? Come on, 11/14 translocation with an increased expression of cyclin D. All right. And lastly is your marginal zone lymphoma. This one, it literally look, you'll see this lymphoepithelial lesion that kind of appears here. And that's really one of the characteristic things, but also when you look at these, you're usually pulling these tissues from the stomach, from the maltoma, so the gastric malt lymphoma, or from a thyroid, or from a salivary gland. So yes, you can have the 1118, but this is the one that we see with usually the H. pylori disease most commonly. So a patient will have a gastric tumor, we'll take a piece of it, we'll find this lymphoepithelial lesion, and then when we look at it under our GM stain and all those, we'll see the H. pylori. And so that's usually what we'll see as the most common association. Sometimes you can see it with the autoimmune disease as well, from the thyroid or from the salivary gland, but this is the big thing to remember. All right, dude, that's insane, right? We covered a lot, but now we're not done because unfortunately these cells, these malignant cells can spread. And what we get scared about is these certain areas that they spread. And so if a patient comes in and we diagnose them with lymphoma, especially non-Hodgkin's lymphoma, that thing can spread. And the areas that we worry about, is it getting into the bone marrow causing pancytopenia? Is it getting into the brain or the spinal cord causing a brain mass, meningitis? Is it somewhere else? The bowels, other nodes, the liver, the spleen, all over the place. We want to know. And so sometimes what we'll do is we'll get a PET CT scan, and that's really the best way. Not sometimes, we always get a PET CT scan in lymphoma because we want to know where has this thing spread, because that determines how aggressive we'll be. It determines our treatment. It determines everything. We'll get bone marrow biopsies if they have really a pancytopenia. And we'll get a lumbar puncture, usually if they're presenting with very severe symptoms. Maybe they have a brain mass, the ring enhancing lesion, maybe they're having meningitis symptoms, maybe they're having some spinal cord involvement. Then we'll do a lumbar puncture. All right. The PET CT is the key thing here. And the reason why is you're going to see these images that pop up here. And you see how we see these kind of black dots. This is really what we're looking for to say these like black dots are kind of hot spots. It's indication of a lot of malignant B lymphocytes that are kind of circulating around in these lymph nodes, or kind of chalked up in these lymph nodes. And this helps us to identify its staging based upon what's called the Lugano classification. Used to be the Ann Arbor. The bone marrow biopsy just tells me if I tap into the bone because the patient has pancytopenia and I take that and I examine it, am I going to find these malignant lymphocytes present in that bone tissue? And that's causing them to crowd out the marrow. The lumbar puncture, I'm tapping into the cerebrospinal fluid to see, is this causing meningitis symptoms? Is this potentially causing some of the spinal cord involvement? That's when I would be doing that to see if it's spread to the brain or to the spinal cord. All right, I want to see those malignant lymphocytes there. Now, after we've done the PET CT scan primarily and it showed us some extranodal disease, if we've done the bone marrow biopsy to show that it's the reason for their pancytopenia, if we've done the LP to show that that's the reason for some of their brain and spinal cord manifestations, then what we can do is we can use the Lugano classification to determine what stage they fall in. So if I see on the PET CT scan, most important one, PET CT, I see this hot spot right there. All right. If that hot spot is getting hit, that's one single lymph node region, that is stage 1. If I look at this one and I'm like, oh shoot, okay. I see that they got a hot spot here and they got a hot spot here. All right. That's 2 or more lymph node regions on the same side of the diaphragm. And all that means is here's the diaphragm. We're going to go kind of above it. If you look here, and this is above the diaphragm, you have 2 of these hot spots on the same side, which is above the diaphragm. That's stage 2. If I go over here and I find a hot spot here, a hot spot here, and a hot spot there, and oh shoot, there's another hot spot. If I look at the diaphragm, I got 3 hot spots up here and 1 down here. I have lymph node regions on both sides, up and are above and below the diaphragm. That's stage 3. And lastly is if I do this and I see, oh my goodness, it's everywhere. It's in the liver, it's in the spleen, it's all over the dang place. Or I get a LP and it shows that there's involvement of the CNS, or I get the bone marrow biopsy and it shows that it's in the bone marrow. It's all over the place. That's stage 4. All right. And that's kind of how we go about determining this. All right. In a systematic approach. Now, one of the things that you'll see sometimes maybe in the vignettes is you'll see the patient has listed, hey, we have a patient with non-Hodgkin's lymphoma and they have stage 3 BX. You want to know what that B or A or X means. A means that they don't have B symptoms. B means that they do have B symptoms. And X means that they have really bulky and large lymph nodes, usually greater than 10 centimeters. And this is things that we just add on to add extra classification there. And sometimes we'll even put like E, you'll potentially put like a little E portion, but I think that you usually explain within the stages and they'll kind of explain that a little bit further sometimes. All right, like extranodal involvement, especially for the spleen and the liver. All right, my friends, this is crazy that we just covered all of this. That pat yourself on the back. We really investigated lymphoma to the top level. The question now is, all right, I diagnose it. How do I treat it? Well, Hodgkin's lymphoma, usually it's got a better prognosis than non-Hodgkin's. And usually the therapy is pretty consistent. You usually do radiation therapy if it's very localized, small areas of lymph node involvement. So stage 1 and 2. Maybe you got like a lymph node here, maybe another one here, or maybe one here, one over here. You don't have it too dissipated. So you can use radiation to localize it on those 2 areas or 1 or 2 areas, okay? And that would be beneficial for that. Usually another thing that we'll do in combination with radiation therapy is we'll add on chemo. So we'll hit the radiation to those lymph nodes and then we'll add on chemo to really kill some of those other remaining cancer cells that the radiation misses. And the ABD regimen is adriamycin, which is also known as doxorubicin. B is bleomycin, vinblastine, and dacarbazine. This is usually a combo that we'll give in conjunction with their radiation therapy. We don't do this as much unless it's super, super aggressive. Oftentimes we'll just do multiple cycles of ABVD instead of doing B-ACOP regimen, but you can do this. It's bleomycin, it's etoposide, it's adriamycin, it's cyclophosphamide, oncovin, brocarbazine, and prednisone. And we'll do this in really, really refractory cases or stage 3 and 4. But oftentimes what most people will get is they'll just do an extended cycle of ABVD. So just remember that, write that down, that you can do multiple cycles of ABVD or the BIA-COP regimen. It kind of just depends. So putting this all together, stage 1, 2, hit them with the radiation therapy and combine on the ABVD. For stage 3 and 4, you can either just do multiple cycles of ABVD or do the BIA-COP regimen. All right. Now, non-Hodgkin's is a little bit more advanced because this is super aggressive in some of them and they can spread. So we get a lot of other kind of like little miscellaneous things that we have to manage. So rituximab is usually a good one for any type of B-cell lymphoma that presents with a CD20 positive. So you have to have a positive CD20 on immunohistochemistry to give them rituximab. And so we really only give this in the indolent non-Hodgkin's lymphoma. So that was your follicular and your marginal zone. So the rituximab antibody, you need the CD20 protein, and the reason why is rituximab binds to the CD20 on the B cells. So if you don't have it, it's not going to work. When it binds to that, all it does is it kind of signals your immune system to kill these malignant B cells. It's kind of cool. And so you'll have these antibodies binding to the CD20, and then macrophages, T cells, natural killer cells can come there and then induce killing of that cell. Or they can bind to the CD20 and tell complement proteins, C3, 4, 5, 6, 7, 8, 9, come make a membrane attack complex and boom, kill it. Another thing it can do is it can actually trigger a direct mechanism of apoptosis. And so these are cool things because essentially you're trying to kill these malignant B cells that are causing these diseases. And so it's really good, I'd say, in the follicular and in the marginal zone lymphoma. Now, our CHOP regimen is a classic one that we give to our patients. It's usually rituximab, cyclophosphamide, hydroxydonorubicin, which is doxorubicin, oncovin, and prednisone. It's a common regimen given in non-Hodgkin's lymphoma, especially if it's very, very the aggressive types, diffuse large B cell, Burkitt's, and mantle cell. So rituximab usually can be given on its own in maybe follicular and in marginal zone. And then our CHOP, which is rituximab plus all these other ones we need in the more aggressive types. Now, one other thing is if a patient has marginal zone lymphoma and they have H. pylori, oftentimes you may not even need to give an extended regimen. You can potentially just treat their H. pylori. And so that's also something to remember, especially if it's marginal zone lymphoma that's occurring in the actual gastric malt. You could potentially just treat the H. pylori and they'll get better. Intrathecal chemotherapy is something that we also do. Think about it. Diffuse large B cell, it can spread to the brain and give you a tumor. You can also get this to spread to the meninges. It can spread into the cerebral spinal fluid. It can even get into the spinal cord and make extradural tumors. I mean, this stuff is pretty important that we don't let that happen. And so in diffuse large B cell lymphoma and maybe even Burkitt's lymphoma, we can put in an Ommaya reservoir as giving them this medication and preventing that spread right into the cerebrospinal fluid, or we can just do lumbar punctures where we squirt it in right there. Either way, we do this in usually very, very aggressive non-Hodgkin's lymphoma. Diffuse large B cell is the primary one. If they're HIV positive or they have AIDS, that's another one you better be giving this intrathecal chemotherapy. And the last one is if they have, and I mean very, very extensive extranodal involvement. It's all over the place. It's involving sinuses. It's involving the testicles. It's involving weird areas that we'll talk about in a second. You should probably take the chance and say, if it's going all over the place, I got to be concerned that it can get to the brain. And that's when we do intrathecal chemotherapy. So you either do it right away if they have diffuse large B cell, or if they have another type of non-Hodgkin's lymphoma with HIV, or they have a lot of extranodal involvement. That's when I would be doing that one. Radiation therapy is really only reserved for certain cases, like if a lymph node is only like 1 or 2 lymph nodes are involved, and that doesn't happen too often with non-Hodgkin's. If you got a bulky mediastinal mass, that may be another one that's causing like SVC syndrome. That would be a really, really important one. And if you have spinal cord compression, oftentimes, if you have an extradural tumor that's pressing on the spinal cord, the first thing we'll do is we'll hit them with IV dexamethasone to really bring down some of the vasogenic edema. And then we'll reach out to radiation oncology, or we'll reach out to a neurosurgeon and say, hey, I got this patient. They have spinal cord compression. I gave them dexamethasone. I confirmed on the MRI that they have this tumor present. Would you want to do surgery? or radiation oncology, would you want to do a external beam radiation therapy to really kind of help out with that reduction in size quickly? And so those are usually what we would do is radiation therapy, or we may even go and debulk the tumor, or maybe do a stabilization. So those are things that can be considered. All right, my friends. So I know that this is a lot. When you're kind of thinking about, all right, when do I give rituximab? I kind of know some scenarios. When do I do the R-CHOP? Okay, when do I add on the quadruple therapy? Who do I give the intrathecal chemotherapy to? And when is radiation therapy kind of good? I kind of got an idea, but let's really put it all together. So if I told you that I got a patient who has follicular lymphoma, or they have marginal zone lymphoma, these are your indolent ones. Indolent ones respond well to rituximab, especially if they're CD20 positive, because you have to have that protein for the antibody to bind onto, the rituximab, which is a monoclonal antibody. Now, if they have H. pylori, that's really important to remember, because in H. pylori, you can treat these patients with quadruple therapy to eradicate the bacteria so that they prevent a recurrence. And so sometimes you don't even need rituximab, right? For the aggressive non-Hodgkin's lymphomas, Burkitt's, diffuse large, and mantle cell lymphoma, it's all about being aggressive. So rituximab is great, especially if they're CD20 positive, but you also have to add on other therapies. And so that's where we'll add on the cyclophosphamide, the doxorubicin, the oncovin, the steroid such as prednisone. And by doing that, you're really targeting these as super aggressive non-Hodgkin lymphomas. Now, from here, if the patient has high risk of CNS infiltration, in other words, you diagnose them with diffuse large B cell, you diagnose them with Burkitt lymphoma, you got to give intrathecal chemotherapy. If they have HIV/AIDS, they are super susceptible to primary CNS lymphoma. You have to give intrathecal chemotherapy. If they already have multiple extensive extranodal involvement, the testes, the paranasal sinuses, the bone marrow, the epidural space, it's only a matter of time until this extends to the CNS. And so from there, you need to give intrathecal chemotherapy, and that's usually with methotrexate, right? For the patient who has localized lymphadenopathy, they got mediastinal masses causing superior vena cava syndrome, or they have an extradural mass that's compressing the spinal cord. In those scenarios, we could actually give them some steroids, especially for spinal cord compression, maybe even SVC syndrome. But what you're going to be doing is doing that to reduce some of the edema. You're going to reach out to radiation oncology and see if they can get some direct external beam radiation therapy right onto the tumor to shrink it down to minimize the compression of the SVC or minimize the compression of the spinal cord. All right. So that's the way that I would want you guys to think about that with approaching the treatment of non-Hodgkin's lymphoma. My friends, this was a monster of a lecture, and I really hope that you learned a lot. I hope that you enjoyed it. I hope it made sense. And man, I love you guys. Thank you guys. And as always, until next time.